Great. Welcome, everybody. Hopefully everybody can hear me. My name is Katya Wald. I'm going to just ask my speakers to turn on their cameras and microphones and join me up here on stage. There comes everyone. Hello, everyone. Welcome, everyone. I'm really glad to have you here. Tonight's presentation is going to be excellent. Just really quickly, I have a couple slides to share with everyone, and then I'm going to introduce Julie. See my slides here. Still figuring, yeah, there we go. So I want to just say, first of all, welcome. Second of all, thank you so much to Caldwell IP for bringing this panel together and for being a supporter of ours for the last, I think it's been like 5 years now. Keegan Caldwell has just been an excellent partner of ours. You know, and I like to say we've known him since he was just small, and now they're growing tremendously. And we're really excited to work with the folks at Caldwell. So thank you to Caldwell for bringing all these people together. Just a little bit for those of you who don't know us, we are the eForum, formerly known as the MIT Enterprise Forum of Cambridge. We were founded in 1978. Our mission is to help early stage entrepreneurs. So our expertise is in helping startup founders build science or technology businesses that are scalable. We are a nonprofit organization. We are equity-free participation. So we charge a small program fee for entrepreneurs to go through our various programs. We focus on early stage, and I like to call us a deconstructed accelerator. And right now we're largely virtual, so we're taking, folks for our classes and our programs, all online. We have about 120. I think that number has grown in the last couple months. Mentors in our network, about 400 paying community, 15 annual sponsors, and about 9,000 people on our mailing list. So we have tremendous reach, and we feel really fortunate for that. We have a bunch of upcoming programs that I just wanted to plug really quickly before we get started. On December 9th, we have a launch clinic, which is our pitch clinic focused on clean tech. On January 12th, we're doing an info session for our Start Smart class, which is our class for entrepreneurs on sort of the nuts and bolts of getting started or pivoting. In February is when our Start Smart class begins, and then we have a couple more launch clinics on the schedule as well for February, April, and then we'll run our Start Smart class again. We have a whole bunch of other things in the works, so this is not it. Keep checking back for our programming. And then, I just wanted to say, membership and sponsorship are what sustains us. So if you're, interested in supporting what we do, feel free to visit that URL to join as a member and kind of help support our work. Couple other quick things. Really want to make sure that those who are here introduce themselves. So feel free to use the chat if you're comfortable and introduce yourself and put your LinkedIn URL in the chat. And then stay after the presentation to do some more virtual networking at the tables we have set up. And with that, I'm going to actually introduce Julie and let Julie get started.
Hey guys. Oh, sorry.
There you go.
Okay.
Go ahead.
Hey everyone, thank you for coming. Thank you to my panelists and all of the attendees. My name is Julie Tolik, and I'm a trademark attorney at Caldwell IP. I'm also a breast cancer survivor, so this panel is very near and dear to my heart. I am on the Executive Leadership Committee for Boston Strides through the American Cancer Society. And this is something that I've been planning for a couple months. It is October, it's Breast Cancer Awareness Month. And this panel really, I say, hits me right in the feels, because everybody here has had some impact on my survivorship. I have people from my personal medical team. I have people that make the devices that were used to deliver my chemo. I have people that I met on Instagram. So I'm really excited to get this discussion going. And thank you for everyone for being here and for your time. And we'll start with introductions from the panel members.
I guess I'm not going to wait for my slides, but I will go ahead and introduce myself while we're waiting if that comes up. My name is Neil Karana. I'm an interventional radiologist, and I am here in South Dakota, in Dakota Dunes, South Dakota, which is on the border of Iowa, Nebraska, and South Dakota. I met Julie through Lena, who you'll be meeting in a bit. As an interventional radiologist, what I do for not only breast cancer patients, but all types of cancer patients is I assist with biopsies. I assist with placing ports, removing ports, dealing with palliative care for patients. And then aside from that, I work in a lot of other organ systems and disease processes that are not cancer. Whether it be benign conditions like uterine fibroids or prostate enlargement in men. It can be arterial disease, blocked arteries or blocked veins. And the whole basis of my field is image guidance and minimally invasive. So basically, we like to say without a scalpel, no cut, no sutures, no scar. And this is the wave of the future. We have been around for 30 or 40 years, but only recently with advancements in technology and, again, intellectual property, a lot of industry support. Our devices keep getting smaller. Our precision keeps increasing. Our safety profile increases. Patient satisfaction, cost, everything improves with interventional radiology. And if it's not available in your area, you just have to go looking for it, because even out here in the rural part of the country, we're offering university level first class care that should be available to every single person who's going through a process, whether it be cancer or not. So I'm honored and privileged to be a part of the conversation. I think that the connection between not only the legal side of things, but entrepreneurs, physicians, and especially patients, I think that's going to be our golden ticket to figuring out what's the best thing to do next in medicine, is to just, like they say, first day of medical school, always listen to the patient. That's where you're going to get your answer. So thanks for having me, and I'm looking forward to the discussion.
I don't know if Dr. Corona, you had something else you wanted to say about this slide?
I'm not seeing a slide right now. I don't know if, does everyone have a slide up on their screen?
It's a slide without a scalpel.
Sure. So I'm not seeing that, but I do remember the slide I prepared. So if anyone wants to know a little bit more about interventional radiology from maybe not so heavy of a scientific perspective, there is a docuseries called Without a Scalpel that is on Amazon Prime, and it's free if you have Amazon. That was created by Isabella Newton, who created a nonprofit called the Interventional Initiative, or the II. And basically what it does is it advocates and educates interventional radiology as a field. Basically, it covers all the things we do for cancer and other conditions, empowering patients with the knowledge that these procedures exist, where they don't have to go under a knife and they don't have to subject themselves to long recoveries or to very invasive procedures. It's just the current state of affairs that even some doctors don't know what I do as a doctor. So the Interventional Initiative was created to put the word out there. A lot of times I get a phone call or an email to my office saying, hey, I heard you do this. Can you help me? And I live 3 hours away. And that's, amazing that happens, but it's also, on the other hand, kind of sad that a patient has to go through that to find the care they need. So that was created, and I do, encourage all of you to at least click it and watch a couple episodes. It's entertaining and also, very informative and exciting. So check that out. I put that up there so that some people can click on it or look for it on Amazon if they have it.
That's awesome, Dr. Prana, and I think it's a good segue because I feel like every time I talk to you, I learn something new, and I had not seen this before, and always looking for ways to educate the patients that that we're working with here at BD as well. So I don't see my slide either, but I will get started. There it is. My name is Lena Schweizer. I'm actually a marketing manager at Becton Dickinson, so BD. And I'm specifically dedicated to the oncology platform. And more specifically, I manage a franchise of chronic vascular access devices. So that's how I came to meet Dr. Khurana, is through implantable ports mainly. But obviously at BD, we have a lot of investment in innovation and a lot of tools that really impact cancer patients and specifically breast cancer patients. So I have been with BD for about 5 years, and prior to that had experience in diagnostics and in life science even, but my passion is for patients. It's very easy to be passionate in oncology and with in the cancer space because everywhere I look in my own family and around me, we're all surrounded by cancer, and it's easy to come in and do what we do every day. So BD is an amazing place to work and has a specific investment in innovation that I haven't seen from other companies. So it's really, I've found an excellent place to be in marketing development. And I'm super happy to be on this panel and having this discussion around breast cancer innovation. So thank you for having me.
That's I'm Samantha Jackman, and I am the co-founder of Boost Innovations Limited, and we're based here in the UK. So I'm joining you quite late at night. It's just lovely to be here. Boost makes of breast form or breast prosthesis that is an external breast form that goes in the pocket of the bra. We had a look after my mum's personal cancer journey. She was given something that looks like this in our national health system, and these are quite commonplace and obviously goes extending in the pocket of her bra, and she found it really difficult to wear it. Then she found it was really hot and heavy and sweaty, and it didn't suit her, and it didn't meet her needs at all. And after spending a really long time trying to find an alternative product that was lighter or airier, but wasn't like the softy kind of breast forms, which were too soft and migrated around and didn't often stay put, we realized that there wasn't that much choice out there. There wasn't anything that we could find on the market. So we started to create things ourselves. And actually, I'm not a product designer. I'm not trained in design. I used to work in arts and culture, mostly with museums and heritage organizations. So it was a big leap for me to sort of partner with an engineer and to really consider how we could address this problem. And we've created something called the Boost breast form, which looks a bit like this, which is light and airy and colourful and soft and beautiful. And we are selling these in the UK. We have plans to expand. We are looking for investment and for other partners overseas now, because we're getting quite popular. Women seem to be really enjoying wearing our products. Quite often that's in the space between having a mastectomy or a double mastectomy and then having a reconstruction. Sometimes there's a gap between that, and that's where people wear our products. And sometimes it's just because they're choosing not to have any reconstructive surgery, but actually they just want something occasionally to wear for certain situations that just gives them a better silhouette or a structure to underneath their clothing. Our breast forms are recyclable, which is really important to us because we are very keen, being based in the southwest of England by the sea. We're really keen that we're not contributing to any sort of plastic pollution. And so that has been a big factor in driving the innovation, because we haven't seen one of these that's actually recyclable before. So part of that was a factor, as well as the comfort and the shape, and also the colours and the vibrancy, and just re-empowering people and considering why you would wear one of those products and how we could make it a more joyful experience for the wearer rather than it being overly medicalized after that treatment cycle has happened. So I'm really excited to be here, and I'm the person that Julie met on Instagram, by the way, just in case you're wondering from her intro who that was. That was me. It's lovely to be here. Thank you.
Okay, it looks like that's the last of our slides, I think, from the speakers, but we still have some more intros. Dr. Ko, hello.
Hi, my name is Naomi Ko. I'm a medical oncologist. I'm sorry, I'm still answering pages and literally just got out of clinic. So I am an academic medical oncologist practicing at Boston Medical Center and have a position at the BU School of Medicine. So I do research, teach, and see patients. And I specifically specialize in breast cancer alone. So that's basically where all of my interest really lays. And thank you for the invitation. And I hope I can be, helpful in the discussion today.
Is that a puppy that you have?
Yeah, I have we have dogs that are part of the hospital Healing Pups program, and they're in my office, so excuse any barking if you.
Oh, Fenway. Is Fenway there?
Yeah, Fenway's here. Yeah. Yeah.
Dr. Ko is my oncologist on my team, so that's how I know. I know so much about your family and your dogs.
Yes.
Thank you.
Yep.
Dr. Cassidy, hello.
Hi, thank you. Sorry, I'm also running a little bit late from clinic, so joined a little bit late. Apologies for that. But I am a surgical oncologist at Boston Medical Center, also an assistant professor of surgery at BU School of Medicine. About 75% of my practice is breast cancer surgery, but I also do some surgery for other cancers like melanoma and sarcoma. But again, the majority of my practice is breast cancer and practice sort of the full spectrum of options for breast cancer surgery, which really we've seen a lot of advancements over several years even. So, kind of the history of surgery for breast cancer is actually a really remarkable one in terms of how things have progressed and changed based on landmark clinical trials and also new technology. From the days of the radical mastectomy to breast conserving surgery and now nipple sparing mastectomies and changes in terms of management of the axilla. So anyway, thank you for having me.
Thank you. And Lisa.
Hi, everyone. I'm Lisa Labadini. I'm a senior manager with the American Cancer Society. I've been with the Society for almost 9 years, more specifically working under the event of the Making Strides Against Breast Cancer event of Boston, which is a 29-year-old event that really spawned all the strides, or the strides movement across the country, with now over 200 events where folks who are somewhere in their cancer journey or survivors or communities supporting someone within the community come out and help us raise awareness and funds for breast cancer research. It is more than, I think the folks that come out is more than just coming out in October and helping us raise funds. We have folks that are working all year round on this particular event. As Julie mentioned too, we've just, looking back at, we're facing our 30th anniversary. Certainly a lot of progress has been made in the field. But we have decided to put together an executive leadership committee and spoke with Julie and recruited her to be one of our ambassadors this year and hopefully next year to help us sort of think about what's happening in the field, how we're delivering information, listening to survivor caregivers and people's experiences, and what more we can be doing. So happy to be here and share a little bit about what the society is working on.
Thanks, Lisa, and that's perfect. If you could kind of give us some more details and kind of set the scene for what is happening from your perspective in breast cancer today.
Sure. Well, very specifically, the American Cancer Society's mission is to save lives, celebrate lives, and lead a world and fight for a world without cancer. And we do that in a number of different ways. I think if you talk to most people and you heard the American Cancer Society, most people know us from our research. And certainly we do that well, having raised a lot of funds and supported a lot of innovative work in the field. We also share expert information through an 800 number that is staffed 24/7. We support patients with programs like a Road to Recovery. So some of the barriers to folks getting treatment is, how do you get to treatment? If you're in Western Massachusetts and need to come into Boston, a number of days per week for your treatment, and you're living alone, how do you do that? So we have a volunteer program that's very structured that will be back online after the pandemic, that support folks getting to and from treatment. We also have a Hope Lodge, which is, we're very blessed to have that in this area, where donations support the lodge to provide free funding for people to come and stay. They have to meet certain criteria, but basically they're able to come and stay to receive their treatment. It could be a month, it could be a couple of months, for free of charge, which again is another barrier for folks, that might not, if they're in Western Massachusetts or out of state and their doctors are here for their care, it's very, very expensive. In addition, we also encourage prevention. So anything, whether it's through the Making Strides property or any of the other things that the society is doing, we always encourage screenings. Make sure, be an advocate for your health, get out there, get screened. Particularly when we're talking about breast cancer, we want to use October as a reminder for folks to go get their mammograms. So I think we've all, sort of to set the stage, this is always something that we've encouraged and part of our messaging for participants and the general public is to go out and get their mammogram. But particularly since the pandemic hit, the last 19 months have really, really tossed sort of a monkey wrench into a whole bunch of things. And so very specifically at the height of our pandemic last April and May, the Society conducted 2 surveys. And the impact that COVID has had on cancer patients and survivors has been pretty profound. So I just wanted to provide you with some facts from our second survey. So more than 26% of cancer patients and survivors reported delays in getting cancer care because of the coronavirus. 87% of respondents said the pandemic had affected their healthcare in some way, which was up 51% from the first survey in April. Of those in active treatment, 79% reported delays in their healthcare, including 17% of patients who reported delays in their cancer therapy. Very profoundly, 1 in 5 say that they worried that their cancer was growing or returning due to delays and interruptions caused by COVID. So more so than ever, our mission at the Society as a whole, no matter what event or programs and services that we're providing, I would say our messaging at this point in time is get screened. We want to get folks back on track. We've always done this. We've always promoted this as, early detection, get out there and get your screenings, but more so even with the pandemic, because this is something that, the ripple effects of this are going to be felt down the road. I personally talk to a lot of folks that are in treatment who work as kind of volunteer as participants in our event. And I can tell you that there has been a lot of fright out there, not really being assured in terms of what they should do. And people had been just really sort of paralyzed with fear. So we know we have a lot of work to do. Julie?
Yeah, thanks, Lisa. So this is actually perfect because I want to jump to Dr. Coe and Dr. Cassidy. And in your experience in treating patients, I'm sure you've seen the effect that the pandemic has had on treatment and patients being able to get in that, Lisa is talking about. And I'd like to know, like, what kinds of workarounds, if you will, or innovations or practices did you have to adopt during this time to help patients get the care that they need? And, how did you have to innovate at this time? Either one of you. Dr. Cassidy.
So certainly in the very beginning, when we were really figuring out how to deliver care safely, it really required us to shift our usual treatment paradigms pretty significantly. So for a while, we were actually not able to do operations for breast cancer. And we had to figure out how to temporize so that patients were receiving some treatment when they couldn't have operations, they couldn't come into the hospital. So we had to treat people with medical treatment who would normally have received an upfront operation. And then we had to figure out how, when we resumed operating on people, really how to triage them back into the system, do the patients who were kind of the most urgent in the most expeditious way, and at the same time figure out who could potentially wait. And then as we've kind of been able to offer more in terms of services, how to offer that safely. So by screening patients and doing a lot of testing. And by doing some patient education around the safety of coming in, because many patients did put off their routine screening. And we are now starting to see the aftermath of that with people coming in with cancers that they felt months and months ago, or even a year ago, and were too frightened really to have those evaluated.
Yeah, Dr. Ko, what are your thoughts?
Well, in medical oncology, we did have to do a lot of pivoting, and there was a lot of uncertainty at the time because patients who are mid-treatment and really dependent on dosing scheduling that would make it so they could have the most optimal outcomes were the most frightened. And so despite COVID, we were still open. We never shut our infusion center. We always saw all those patients. And so in a lot of ways, we felt like kind of on the front lines where we weren't going to not see the patients that absolutely needed to be seen physically in the clinic. We sort of powered through that. We did a lot of telephone calls, like Dr. Cassidy said. We had some new patients diagnosed. We started them on medications and pills where we wouldn't have otherwise. We altered chemotherapy regimens for patients to make them less immunosuppressive. We had conferences with our colleagues across town and unanimously agreed on some changes to chemotherapy regimens for which we thought we could still get a really decent outcome, but mitigate the risk of patients potentially contracting COVID and having a bad outcome. And it was a difficult time, to be sure, because of the uncertainty more than anything. But now at looking back at it and it, playing Monday morning quarterback, we didn't lose a single patient to COVID. And that's pretty remarkable. We did lose staff. We lost family members. We lost people. But fortunately, we didn't lose a breast cancer patient undergoing treatment to COVID. So that was a good thing.
I was actually one of those patients that was coming in for my continued infusions during that time. So it was definitely a different vibe. And I'm grateful that, I was able to continue to do that. And, so the pandemic is an example of innovating on your feet, essentially, and having to go with the flow and figure things out, as they come with so much uncertainty. And I think, when we hear the word innovation, we often think of this in a scientific context and in a technical context, but there's also innovation in the context of the patient experience, whether it has to happen because of a pandemic and you have to adjust, or whether it's the thought out and bringing more humanity to patient care. And so I'd like to ask Dr. Khurana, because this is something that, we chatted about, I think, together. How do you think the patient experience has evolved, and what kind of work is there still to be done?
That's a great question. Obviously, it's very deep and existential in a lot of ways, but that's, I think, what is important to focus on as we move forward in treating patients. My field basically focuses on minimally invasive and, less complications. We've talked about that, about what I do. And it does give me the opportunity to talk to the patient face to face, and I'm usually their first point of contact when it comes for a biopsy. Now, whether this be a breast biopsy, a lymph node biopsy, or any other type of biopsy, head to toe, usually I'm the first person who's going to be putting a needle into them. So I think that my experience is that is a significant moment to have that patient's journey start on a good note. Really, they are scared. 100% they are scared. And there's so much surrounding cancer with survivors and getting into the mix with, we're going to talk about the pink ribbon, I'm sure, eventually. There's so much going into that. But when you're a brand new cancer patient, that's the last thing on your mind. And then, come after the biopsy, now you have to get a port placed. Again, this is the start of your journey and you're scared. So the patient experience, what I've noticed is that we need to pay more attention to it, basically. We need to listen to the patient from the beginning, hear their expectations, set those expectations. As long as you manage a patient's expectations, the outcome's going to be good, even if the outcome is so-called bad. I just think managing the expectations is a big part of treating a patient, is to listen to them. Hey, what are you expecting to happen at the end of the day with this, whether it be a port or a biopsy or a diagnosis? What are they thinking when they go to bed at night about what's going to happen next week? So to hear those parts, really, I think it changes the whole paradigm. Obviously, I have some very talented, smart people here in this room with us, and all of you play a crucial role in this. But I think the human touch from the get-go, right out the gate, needs to be. We need to pay attention to that. Now, as we kind of progress into personalized medicine, where that term, it carries a lot of weight. Not only personalized from a genomic standpoint, from a biomarker standpoint, from personalized medicine down to the science, but there's also that side of personalized medicine that we can't ignore, which is also listening to the patient.
Yes, and I just to kind of go back to Dr. Coe and Dr. Cassidy, I can speak to their bedside manner and their my experience with them, and I was so lucky and fortunate enough to have a team that is compassionate and patient and empathetic and would talk to, no question was a stupid question. And, it's refreshing to hear, Dr. Khurana, that, you're kind of on the same page with that, because I speak to a lot of survivors who unfortunately meet with their first contact in the context of a breast cancer diagnosis is with someone who has a horrible bedside manner, who tells them their questions are not important, who tells them that they shouldn't worry about it. And, at some of the leading cancer institutions. And it's disgusting to hear, and it makes me very sad. And so I'd like to ask the doctors, when this happens, do you think this is a personality issue, or do you think it's a product of the culture of medicine?
Take that one, and I think I clicked off before Dr. Coe did, so I'm sure she has a lot to say. I definitely think it's a combination of the two. I don't think there's, it's multifactorial for sure. They said, the person who finishes last in medical school, what do you call them? You call them doctor, right? I mean, the choice of going into medicine is, and that's a whole other discussion of who's going into medicine and who's coming out of it. I think leaves a lot to be desired about who, the smartest person in the room definitely maybe shouldn't be a doctor, or sometimes they should. And I think we need to start looking at some of those metrics on how are these people as far as being compassionate, understanding, and being able to communicate to the patient on a different level other than just a scientific level. Now, the problem with healthcare, in my opinion, is that, I think there is a level of, corporatization of medicine. A lot of doctors are employed now by the large health systems. These health systems need to keep squeezing resources. Look at what's going on in the nation as far as nursing goes. I was just talking to the CEO of our hospital today, and we have a small rural level 2 trauma center here, but we're absolutely drowning without nurses. So as medicine becomes kind of a corporate entity, it's going to be, the burnout factor, resources getting squeezed, and physicians and healthcare providers of all types are starting to get a little bit, disinterested, which is so sad because we all went into this for one reason. You remember your first day of medical school, you wanted to help people, right? And if you lose that anywhere along your journey, something is grossly wrong. I go to work, I know I'm going to be helping people, so nothing else matters. And I know that sounds kind of like BS, and no way, that's not true. No, it's 100% true. I just wish that was for every single physician out there, that they had that same sort of feeling every day. And so I definitely think the system itself is not supporting healthcare providers in having that feeling. And obviously there's a million reasons why that is, I think, beyond the scope of this talk, but I'm interested to hear what Dr. Koh has to say.
Well, I think that my feeling on this is exactly as Dr. Khurana, you said as well. It's a combination of both things. I think it's a combination of the system for sure, and also personality. I'll speak to the system issue, as I think you're right in that we're getting squeezed in terms of the number of patients we need to see, and we need to be billing, and we need to be meeting a benchmark. And the more corporatization that, occurs across the country for medical, facilities, and the concern about the bottom line is just putting pressure on the providers to just see more volume. And that volume pressure is you're going to take a hit somewhere when you're just churning people through the system. And that feeds a very high burnout rate for doctors, where you're just like, I'm not seeing enough patients because I'm not going to make my salary. And that threat can be threatening. So that pressure is real. And that's why I work in an academic hospital. So I can offset some of that clinical pressure with research that I love. And it's a different culture in academics, but I think in like the private practice area, it's very stressful. And so you're just doing this wheel. But I also want to say that I do think a personality is a huge part of it as well. And I think that, like, we don't teach compassion or empathy or how to talk to people in medical school. We teach the Krebs cycle and what kinase is going to phosphorylate which kinase, in the cascade that creates, cancer issues. We're not teaching that in medical school. They are more and more, actually, than when I went to medical school. It's definitely better, but we're not quite there yet at those softer skills that people find are soft skills, but I find them to be everything, because everything I do depends on my patient trusting me. And if I have the trust of my patient, then I can give them the best care possible. But if they don't trust me, then it's like, we're done right there. And I will also finally, my last point about this is very personal in that, at Boston Medical Center where we work, I really like to emphasize how we don't treat breast cancer. We treat the woman who has breast cancer. And that's very different than other cultures, even close to us here in Boston. where there's a real energy about being really myopic, about we are cancer, breast cancer, this, and this data says this, and this study showed this, and this. But sometimes your patient does not fit into that study. And you need to, step back and know your patient well. And I think that we do that really well at Boston Medical Center because we have traditionally been the safety net hospital. And when you are a safety net hospital, you take care of anyone who walks through that door. You don't pick and choose based on insurance. You're going to take everybody. And so when you have a team of doctors that has to pivot between taking care of a prisoner and then taking care of a CEO's wife, you learn that communication skill at a level that I think is very different. And I know because I trained at some of those other hospitals where you see the same demographic and you learn that demographic speak. You're not really pivoting in the way that we're forced to at Boston Medical Center. And, one morning I walked outside of our clinical building and there was a Porsche right outside the revolving door. And right behind the Porsche was the Correctional Institute's van transport. And I took a picture on my phone and I said, this is essential BMC. We are providing exceptional care without exception. And the providers are forced to take care of homeless women, women who have addiction challenges, women who are totally upper class and want you to explain the data on the latest study that they read because their friend brought it to them. And I love that challenge because my job is to serve. And my job is to make sure that I'm meeting the needs of every woman who walks through the door, whether you're Black, whether you're Spanish speaking, whether you're anything. Like, we got to be able to do that and do that well. And that is the type of stuff that in our segregated hospital system, sometimes we don't mix enough. We don't see enough diversity that's training doctors how to do that. And I think that's what makes us special. So, and that's what forces us to have that kind of culture. I had 2 patients today tell me they had been across town and they chose BMC. They came back to BMC because they said it just didn't feel like home. It just didn't feel like I was seen. And I'm like, well, you're seen here. That's our job. And that's what I really pride us on. It's not easy and it's a lot of factors.
This is going to sound like such a BMC plug, but I mean, that's why I stayed there. I had Mass Health for a long time. And even when I had private insurance, I stayed because I loved my team. I'm so happy and grateful for that. And I just wanted to add one thing to your diverse demographic, if I may include men also, because I think that they often get left out and they can get breast cancer. So I want to make sure that that's something that we just acknowledge here too, in honor of, awareness and everything. Dr. Cassidy, do you have any further comments on what Dr. Coe has provided?
I agree with her, as I always do. It was well said.
Awesome. Thank you. So kind of along those lines, I want to talk a little bit about, actually, Dr. Coe, I'm going to put you kind of back on the spot again, because I know a lot of your research has to do with demographics and different races and their treatments and stuff. And although the pandemic seems to have impacted treatments, I think you had some recent articles published and you've had a busy summer. So could you tell us a little bit about what you've been working on for your research? And most recently, I think you had a publication in August, if my poking around online is correct.
A bunch of publications actually, and I've been working pretty hard since I became a doctor with a singular mission. Sorry, Fenway's just at the door here. To basically provide as much research as possible to delineate differences in disparities in cancer care. So that, like, I'd say if someone was like, how would you talk about what you do from a research standpoint? And mine is to provide as much information and knowledge that we can to make sure that all women with breast cancer have the best outcomes, not just some, but all. And whatever it is that I'm working on, I try to make sure it fits under that guiding principle. Like what I'm working toward is uncovering any discrepancies, disparities, challenges that would prevent someone from getting the best outcome that they can. And a lot of times those issues fall along racial lines and poverty lines, so set sociodemographics that impede, people from getting the best outcomes. And that has been a real research focus. And when we talk about that cancer disparities, we're talking about it across the entire spectrum of cancer care. So can you get screening? Do you have insurance? When you get screened, how late is it? We often see women present late with later stage breast cancer who don't have insurance. And I did have a bigger paper published in JAMA Oncology where we did outline exactly how that happens with racial disparities, that you're going to see a stage migration of later stage in, racially diverse patients, namely Black women, and that portends worse prognosis always. That is mediated by insurance. So that's a big, big factor. So sort of highlighting those things, getting that out in the news, making people aware of those challenges, why insurance is so important for women, people who aren't connected to the healthcare system, they don't have a primary care doctor. You feel something, you feel a lump, you're like, what do you do? Where do you go? You don't have a doctor. You don't, how do you navigate the system? You don't speak English. Who's going to listen? You can't pick up the phone. So women walk into the emergency room. The process of our delivery care system is broken in a lot of ways for the most vulnerable patients. And then on the flip side, a lot of my research is pivoting toward genomics and biology. So we've started a new breast biopsy translational research program here at Boston Medical Center because we see all the diverse patients. We are now inviting women of color, particularly, but all women really, who come to our center to donate a research specimen from their biopsy. So Dr. Khurana with the IR also could be considering how could you create a translational research program where you can get research biopsies from patients and then you can sequence those. So we're hoping to do some RNA sequencing of tumor types to really drill down on what makes, let's say, triple negative breast cancer more deadly. What can we learn from those genomics? And we are doing that project here at BMC. So those are some of the more technical research type things that I'm also working on that aren't part of the delivery aspect of breast cancer, but getting into the biology as well.
Julie, can I add something here? I just we do a lot of work at the Society with disparities and looking at barriers to care and whatnot. And we do have an arm of the organization, the Cancer Action Network, which we refer to as ACS CAN, that they're a lobbying arm. They're a sister organization to the society. And they're out there every day working hard, speaking with our elected officials to deal with issues of insurance and a lot of other issues. So it is something that, again, is in the fabric of the society, and that's very important because, we live in a part of the country where we have great care, but we're blessed because we're here. If you were maybe another part of the country too, you may not, for a lot of different reasons, be provided with the same sort of resources.
really good point. I'm actually funded on an ACS grant looking at research disparities. And one of the things I will say, and the ACS CAN group is phenomenal, was that when I went to one of the PI meeting at headquarters in Atlanta with the American Cancer Society pre-COVID, they do a lot of incredible epidemiologic work at the American Cancer Society, reporting on things like disparities and outcomes in breast cancer, particularly racial disparities. They have a real desire to help in that field. And what they've seen in more recent years is that the quote blue states of in this country is seeing less disparity. And in fact, in Massachusetts, the disparities they're not really evident anymore, because we've for so long been providing mass health and healthcare insurance. And so screening rates, there's no discrepancy in breast screening rates between Black and white. And so we're seeing a real equilibration of that with the insurance. But I would say in the red states or in rural areas, that gap is actually growing wider. So that's part of the dialogue there.
Great. I just want to take a second. If attendees have any questions, you can feel free to type them into the Q&A. You don't have to wait till the end, and I will try to get to them as we go along here. So we've talked a lot about esoteric innovation and the patient experience, and slowly we started getting into more, technical innovations with talking about Dr. Koh's research. And so I want to now speak with Lena a little bit and talk about ports and the importance, like the difference that it makes. What is a port? I didn't know what a port was when I started this whole journey. It's often you're going to get chemo with a port. It's your first step in getting treatment and starting your treatment. And, for me, it was, I met with Dr. Cassidy. Dr. Cassidy sent me to Dr. Koh, and Dr. Koh sent me to get my port. And the next day I was, getting my infusion. So can you talk about what the port is a little bit, and why is it so important, and why is it so special? And of course, Dr. Khurana can chime in on this too.
Yeah, and hopefully you can hear me okay, because I know my audio has been a little sketchy, so let me know. And honestly, it's great to even hear an example of that process working as quickly as it did for you, because from a global perspective, because I do manage the global business, it's obviously, we are, in fact, Lisa, very lucky here in the US, because that's not how it happens around the globe. But as you know now, ports are specifically for vascular access, and
they're the only, you could show.
Yeah. So in the history of ports, which we're coming up on our 40th anniversary next year of the first implanted port. Wow. This is the very first barred power port. Bard was acquired by BD a few years ago. And as you can see, hopefully it's purple, and this one is quite large and titanium. So in 2006, that was the very first power injectable port that we launched. And obviously it allows for any kind of repeated access to the vasculature. So most of our chemotherapy is delivered through a port.
Can you explain what the power injected part means?
Sure, you bet. So up until that point, for contrast enhanced CT scans, most of the time you want to add contrast media to an imaging study to improve the quality of that image. And the best way to do that is in a tight bolus. So you want that contrast, in a timed manner to get where you need it to be to that tumor location. And the best way to do that is through power injection. So you're basically pushing that contrast dye at a high rate of speed. But in order to get that quick burst of contrast media, it creates a lot of pressure inside the device. So there's a lot of innovation to basically design and test our ports to handle that pressure without, succumbing to some kind of mechanical failure. And that really allows for that improved image quality when you're looking for a CT or MRI. So 2006 was the very first power injectable port that was ever launched and by BD. And now in 2021 in the US, it's about 95% of ports on the market are power injectable. So it really changed the landscape of what was previously being used to deliver treatment. So they can still, you know, obviously you're never going to be power injecting chemotherapy. The whole point of a port is to have your attached catheter delivering that toxic chemotherapy to a really high blood flow area in your superior vena cava. So that's the original intent, was just to have that repeated vascular access. But with the invention of power injection, that added another layer and another use of that port could be used for. And as you know, a cancer patient has 1,000 reasons to need access to a vein. And alternatively, you'd be going for a peripheral vein every time you came in for a blood draw, for hydration, for antibiotics, for all of these things would otherwise have to go through some other line. And over time, those peripheral, it gets harder and harder to access those peripheral veins. So this really provides a solid long-term way to both take blood out and then deliver any kind of medications into that patient over the course of their treatment. So, and we know, I have heard of patients that keep their ports upwards of 17 years. That's not typical, but to just, we know what happens. As long as it's still functioning and it's maintained properly, they can stay with that patient for a really, really long time. So to have a high quality device that continually performs is really critical. And unfortunately, to your point, I don't think most patients go into their cancer journey even knowing what a port is, much less knowing that there are options and who places them, how they're placed, and what features are available. That I think even some of the doctors that I speak to are surprised at what differences a catheter can make on how often a patient, especially in a COVID environment, has to come in to get it maintained and flushed. So there's a lot of education, I think, that's involved in my particular job, but also innovation and continuing to build on that.
Can you talk a little bit more, or Lena and or Dr. Khurana, about how the port is actually installed? And Lena, if you could show the port again and kind of show the pin cushion area of it, I call it, with the little nubs, and how does it get accessed? How does a nurse find it, and kind of explain how it works practically?
Yeah, so I'll show you this really quick just so that you can see how far we've come. This is the most recent port compared to the first one we launched. And this one is full of titanium, as you can imagine, creates all kind of problems for imaging and radiation therapy. This one is completely metal free. This is our smallest Clearview Slim. So they have become smaller and smaller and less metal, down to no metal, even for a power injectable port. But Dr. Khurana can tell you all about how he places them, which there's a lot of innovation, again, that has changed over the years to improve that procedure a lot.
Sure. So basically, as Dr. Cassidy can speak to, surgeons place ports as well. Interventional radiologists, because we are minimally invasive, we don't put our patients to sleep to place these ports. We do give them some sedation so they're nice and relaxed. But I'm usually talking to my patients throughout the procedure, making sure they know what I'm doing at each step of the way. Some patients don't want to hear me talking about what I'm doing. And so I, always communicate that at the beginning of the procedure that, if you don't want to know what I'm doing, just let me know. But it's a really, for lack of a better term, it's a really intimate kind of moment, to be going ahead and making a small incision about an inch right over the or below the clavicle or the collarbone, and be talking to the patient through this process, because when they leave there, that's the beginning of their cancer, journey. But there is about an 1.5 inch incision just below the collarbone, and a tiny little tube called a catheter will ride up under the skin over the collarbone into the vein here in the neck called the jugular vein. So that will leave with another millimeter incision right over the jugular vein. And we use an x-ray machine to see where that catheter ends. We want that catheter to end just above the heart. I know that sounds scary to most people who aren't in medicine, but think about it as all the veins in your body have to bring the blood back to the heart, and it all ends up in one location, in this location called the right atrium, which is one of the heart chambers. So it's a really great place to keep the catheter. It allows for delivery of chemotherapy and for good blood flow for drawing out blood. Now, as Lena was saying, it sounds like, there's a thousand ways to skin a cat. There's 100 different ways to place ports, and I've seen ports, placed into different locations based on patient's preference, based on their anatomy, based on the tumor they have. But that's also who's placing the port. And I think some some innovation in the standardization of how we place these is going to be really important. I have the luxury of fixing other people's problems with ports because I place so many and I remove so many. And it could be being in a rural area, someone might get a port placed, 100 miles out in the middle of a farmland where there's a surgeon who's doing all types of stuff. And, then again, a month later, their port's not working. And I think for a patient who's going through, battling cancer of any sort, the last thing they want is a port that doesn't work. Their oncologist, that's the last thing they want to hear, is that the patient had a bad experience at the infusion center. For the nurses who cannulate the ports, and the word cannulate means to take a needle, and by the way, this is how these ports are used, is once that incision heals up, a nurse will take a needle, put it right through the skin, and access the pincushion portion, as Julie said, which is a little septum. And that septum is a chamber that allows the needle then to communicate with the bloodstream. So it lives right under the skin. And, a nurse who has been sticking these ports for years may not have a problem, but some newer nurses, or if somebody's body habitus is, let's say they have a little bit more soft tissue, it could be quite challenging to get a needle into that port successfully every time. And, when they start infusing that chemotherapy, if it's not going in the right place, that could be also very dangerous. So I think there needs to be a conversation about how can we improve the reproducibility of getting to these ports every time safely, with the patient being satisfied, with the oncologist being satisfied, with the nurses who are cannulating being satisfied. And, I think down the pipeline, hopefully we can improve with some smart implantables. I know everyone immediately thinks about Elon Musk in that field, but it doesn't have to be too fancy. A port that has an ability to communicate with the outside world to make sure that everything is going okay on the inside of that patient. Who's accessing the port? What's the last thing they get? For research protocols, I think having a port that gets explanted and gets submitted to, let's say, Dr. Ko, she could take 500 ports, scan them all, and it'll give a full database of who that patient was, what their cancer type was, who infused when, how, and that data is king. And so I think we can capitalize off of the port being in the patient. They walk around with them, and hopefully, come one day, Lena, I think you've talked about this a lot, is what the innovation could be with making these implantables kind of smart, for lack of a better term.
Yeah, they've come a long way, and there's a lot more work to do. And it really is impressive in the differences, to your point, Dr. Krana, in seeing cases around the globe, but even in the US, there's such huge differences in the use of tools that are available today, as far as ultrasound to access, the vasculature, and, like you said, live X-ray to confirm tip location, and little things like that I think make a huge difference in what we see on the other side as far as complication rates and also patient experience. So it's definitely top of mind for us, is to, like Dr. Krana said, you've already gone through so much as a patient by the time you get to a port placement, and there are still patients that are offered peripheral access for their chemotherapy, even though it's expected to probably be longer term. And given the option, I think a lot of patients are going to choose peripheral access because it's a regular IV, it's what they know, it's what they're used to, rather than the idea of a port placement, because it's such a foreign, most people are not aware of what that exactly means. But once you've seen the difference in something like Dr. Krana's procedure, that's, you see 15 minutes cut to close and they're talking through the whole thing and you're going in and out. It really isn't as scary if there's that level of education about what to expect and setting those expectations. So, but yes, I absolutely agree on the innovation piece. It's twofold. It's one that as medicine has gotten better, I think there are so many different touch points for cancer patients that you now have this, whole slew of different clinicians that you deal with in a day. And that's no exception for ports and who's touching ports. There's one person that prescribes it. That's, our oncologist. A different person puts it in. A different person accesses it. That's an oncology nurse. And you have your radiation oncologist and your CT techs that are delivering contrast enhanced dye. There's, if you come into the emergency department, might have an ED nurse that's accessing it. So with all those touch points, I think there's innovation and unmet needs to having, like Dr. Prana was talking about, that built-in way to connect all of those pieces, because there's no reason why every single clinician that touches that port, that touches that patient, should have access to all of the information. And it, like you said, it's implanted. It stays with you all the time. There's a lot that we can put into it and a lot that it can be sensing and detecting and tracking for that patient, and just, offering better patient cancer management in general.
Dr. Karana, you mentioned, maybe smart ports. Is there anything that you or Lena can share that might be the future of what you guys are up to?
Yeah, I mean, I think a lot of it is, there's a lot of obvious and there's some non-obvious. That's your speak, isn't it, Julie, when it comes to trademarks and patents. But, basically monitoring things, we can come up with like 100 things to monitor, to keep track of. And then someone like Dr. Cassidy or Dr. Cole may be like, why are you even tracking that? That's not important. So I think the communication has to be along all specialists to say, what is the most important thing we need? There's the basics there, a patient identifier, for example. So you God forbid a patient's found unconscious and they have a port. Well, if you can somehow connect with the port and say, okay, this is, Mr. Jones, and he was found, and this is his diagnosis, his date of birth, this is his address, his emergency contact. So that's a very simple, obvious sort of thing. The non-obvious kind of things are going to be, what parameters of that patient's, homeostasis can we track? Their body temperature, maybe their oxygenation level. If we could ever develop a technique where we can track the amount of white blood cells, or the cells that fight infection in the body, that would be really, really important for an oncologist to know. Well, they had chemotherapy, they're immunocompromised, their white cells going up, and they have a fever. Well, if we can get to that before they're actually in the emergency room in full-blown infection, it's going to be cost-saving, it's going to be life-saving, and it's going to make it more efficient. So I think, those types of ideas of ways to track. Now, that's the medical side of things. The other side is the data side of things, which I spoke to before, with again, just kind of keeping a tally of when that port's being accessed, who's accessing it, and what they're getting through that port. That can be, peeled off for research opportunities, I think, which could be very strong. As therapeutics become more personalized, I think it's going to get really confusing really quickly. If we actually get into the realm of what we're doing right now for the COVID vaccine, which is RNA therapy, it's going to get so specific for each patient as we start figuring out these cancer genomics. I think a tracking system would be really important. And what better way to track something is than track it on the patient themselves.
Great. Oh, yeah. I hear Lena's background noise. Yeah.
At least you know when I'm coming. I was just going to say, I absolutely agree. And, that is so much of it. And what we hear from nurses is there's nothing, there are parameters of that, physiological parameters that could be tracked by the patient, but that requires the patient to know that they need to watch out for them and to be reporting in and to, have a method of even down to temperature. There's disparities in being able to take an appropriate temperature and reporting that in and knowing when to report it in. And from oncology nurses, it's nothing more sad than a patient that comes in for their chemotherapy and they're already, septic or close to septic, where had you had that information weeks ago, then, potentially you could have prevented it or caught it sooner and intervened sooner. So that's definitely a lot of, I think, what we can do in the future, but it really just comes back to the patient and improving that process.
I just wanted to bring up something maybe that's a bit of a tangent to what we're talking about. As far as we're talking about empowering the patient here and making the patient knowledgeable about the processes that they're going to be undergoing, a lot of time there is going to be that, patients, there's going to be an education barrier, there's going to be a language barrier, there's a socioeconomic barrier. So, once we pass all those barriers and patients get more empowered and knowledgeable about the treatments they're going to be undergoing, there is this concept also about, too much information is a good thing. You see what happened with the COVID vaccine and the misinformation out there and how that, a life-saving treatment like that is being ignored because of, falsified information going around. But my question is as we empower the patients, I want to get everyone's opinion on what that means for us as healthcare providers and what that means for patients who are survivors or going through the process. I've had patients walk into my door and say, I saw this online, I want this. And maybe it's not the best thing for them, right? How do we start to kind of break down that barrier? And this may be going to the first part of our talk. We're talking, more about that patient innovation and the relationship innovation. I just think it's an important thing to think about. I kind of have a challenge with that, with something called uterine fibroids, which are benign growths in a woman's uterus. And, they get their uterus removed through hysterectomy unnecessarily. There's 600,000 hysterectomies performed annually in the United States, and most are not needed. I do a treatment for fibroids that is done through a tiny catheter through the wrist or groin. And this is a great thing for women, and it's been around for 25 years, but it's not well known. So when I go out, and I hate to say this, but I do advertise for this procedure because I feel it saves women and it saves their uterus and it saves the surgery and the 6 weeks recovery and the possible complications and the cost of the healthcare system. It's an hour procedure I do in my office and they go home the same day. So I advertise for this, and when they go to their doctor, their OBGYN, and said, I saw this on the internet, there's a guy named Dr. Karana who does this, it is met with animosity. And it's met with, oh, well, that's not what you need. Or no, you need a hysterectomy. So that's something that I think we're going to run into more and more as patients are going out there and educating themselves, whether it be about a port or whether it be about a therapy or a new study, and they're coming to your office or they're walking around saying, well, I want this. It's interesting times for sure. The world's getting much smaller and there's a lot more out there for the average person to figure out. So I think it's just a good topic of conversation in this forum.
Sam,
can I there, because we have a similar thing with the breast forms. They're so much lighter an area than the forms, and it has been the advice of some clinics that that's wrong or right or whatever, but that breast form that mirrors the weight of the breast, that is the most favorable. Although in practice, particularly for patients or treated for cancer that are having active lifestyles or quite far on from their cancer treatment, like was sort of 10 years on from her and still was unable to undertake certain activities, was too heavy for her to actually really engage with some swimming and all those kind of things. So I think that there is an element where sometimes research into new alternative ways of doing things is not a bad thing for the patient, has a genuine reason to go down that route. And what we did find initially when the concept of our product was that with quite a lot of skepticism from people Of course, I'm not in the medical, but what we did know was that we listened to women, and I from the UK government's innovation type people, Innovate UK, and what we did was some design research where we really empowered women a platform to say to us, what do you want to be? And the overwhelming answers were just area, and I just need something to give me some shape under my clothes, and I need another choice. I have a gap between these products and these, nothing here in the middle. And that's really what we were, rather than thinking about necessarily what to the medical profession is really important, but it's also one that's just a little outside of that and more about women's choice and how being might be proactively affected afterwards. And we've been actually working on some products as well to go alongside, have reinvented what that breast form might be and empower women to make choices about the size of their breast forms as well as they are, so whether they have a black one or a pink one, you know, or a glitter, we can make glitter, and whether they have ones that are like that to express they're looking for a particular shape, particularly if they've had a double. All of those things are being empowered, and we're working on to kind of smooth that process over, more power with the individual patients that would suit them. And yes, it is a different type of sphere, but we have more, even with the NHS procurement here, moving towards thinking that more options available like ours better for the patient, because there's more ways, avenues to choose from to support their well surgery.
Sam, I want to kind of continue down this path and your innovation. You know, personally, you mentioned, you know, you're not in the medical industry, and you don't have formal training in medicine or a health background or anything like that. And so when you were met with some of this pushback and opposition to innovating these products, how did you overcome that and advocate for yourself as an innovator in this space when you don't have the quote unquote same experience of the people that are telling you, no, this is not the right thing?
I think it's just having the evidence we work with and just make voices, and the co-design process with about Boost Innovations is really embedded into what we do. Now we're going to be on the right track with our product design, and that's what we've had to do, particularly with the funding that we've had from Strand in the UK, that has helped to women to workshop with them, to do surveys, to do feedback. I have women who regularly and say, hey, have you thought about doing this, or what I really need to rapidly prototype. So we have our innovation space here in Cornwall in the, it's a little workshop, it's owned by us, and we can at a speed that people can't really get their head. I can take a phone call. For example, I've worked with where the daughter had a child affected her chest growth and therefore forming, and she was getting a bit self-conscious, 13 years old, and within 2 weeks we were rapidly a similar design and similar concept, make a bespoke product that was the right size and dimensions for that lady, so that we were able to just quickly meet her needs when she had been. The options were, you know, one of these, but with the sticky pad, and obviously for a young girl who's feeling body something that that she was very keen on, making her a sparkly pink breast form like this was much more acceptable. She was able to sort of move on with she was wearing, the types of underwear she wanted to wear, and all that kind of. So those things are really important to us, that we're here to listen. Company, we don't always, if I'm totally honest, see our products as medical, and sometimes them in certain contexts as an accessory shaper, or those types of things. People will wear those, like my mum who business, because of the medical history that so we kind of straddle that line. We don't want to give something that's kind of a view, but we are here what women are telling us, and to try and efficiently do something about it. Our digital technologies, that we can use computer vision to actually more about the individual woman and their shape and sizing needs they'd like to create, and to help them to breast form from us, either as a bespoke model or as something to give an idea of best fit, so that it obviously played a big part here in the UK, the hospital system. There was a lot of women in the COVID period who couldn't go into hospital, get fitted with one of these, and they were essentially, we said, we've just been left breastless for reconstruction, and we might be scheduled in for more surgery. Urgent, we're not allowed to go into the clinics to prosthesis fitted, because the clinics are essential appointment, and with them we just don't know these ourselves online. How can we find something? Can we try your thing? And that was a really interesting, and we started to create this digital technology to support, to have more choice, to feel more empowered in decision making, of saying, yeah, I'm confident I could buy and that it would fit me, as we can get it to fit. So yeah, working on those kind of things for a while, which is really.
Yeah, that's amazing. You're even more further along than I had realized, and I think in one of our first conversations, I was like, I wish I had found you sooner in my own journey. But
sparkly boobs, Julie. Then
I know. It would have been a lot more fun than the beanbag I had to use. But this is great. I know we're coming close to the end, to the networking portion, but I have a couple more things that I want to throw out there before we get to that I think are important, and that I want to kind of I want to flesh out a little bit. And Sam, being part of the Instagram community, I think this is something that you'll be maybe the most familiar with from this group, is that there is a marketing, or maybe anti-marketing even, if you will, campaign out now called, for it's Breast Cancer Awareness Month. What does awareness even mean? There's always this, portrayal of breast cancer as pink and fluffy and bows and ribbons and, haha, we're wearing tutus and, raising awareness. And, some people are of the mindset, there are a lot of survivors that, will say pink doesn't save a life. Pink means nothing, and they call it pink washing in October, or Pinktober. And then, there's another mindset that, any awareness is good awareness. So if somebody is thinking, if somebody sees something pink and they think about breast cancer, then that's one more person that has it on their mind enough to maybe go get checked, or maybe talk to their friend about it. And so this pink washing campaign is something that has started within the breast cancer community, I think this year particularly. And it is defined as, pink washing is defined as a marketing tactic through the exploitation of breast cancer for profit or for public relations, and the exploitation of survivors and their pain and what they have gone through. And this can be, you know, companies that make pink products only in October and call it breast cancer awareness, but none of the profits of those products are going to anything that has to do with breast cancer. Or some companies will continue to make products and call them pink and say it's breast cancer awareness, but the products are actually harmful and linked to disease. And so I would love to know your thoughts on this. And, you know, do you think any awareness is good awareness, or are we being exploited?
I'd say just a little bit about that. Could answer that question, and it's really tricky, which is you're bringing it up. I mean, ultimately, for somebody like me who's trying to build, because I'm not medical. I mean, we are trying to we do it for the good of people and support that we can give to women, but we are building. We are trying to sell these. Are very aware that we have to maintain a brand authenticity. Cancer and women's health products are obviously business. There's no issue there for a commercial entity as which is a limited company, and we are here as a purpose company, but we are here for profit and we do what we do. But it is hard when you do see a kind of tokenism there with a, and I think that understanding that brand and the brand history, you to judge those things, and just having to interrogate those things and to of what you're buying and how you're buying it, the type of consumerism you just have to on a case-by-case basis and read about those issues behind other campaigns. I think if you go into it with your eyes open, then that's much better than just it under the carpet, essentially. Yes, that's just the thing that I think comes from it, is that you just need to be critical and engage with if you want to, but with just that element of awareness.
Has anyone else on the panel heard of this campaign? Lisa, what are your thoughts?
Pink washing, or the phrase pink washing, has been around for quite some time. There are a lot of companies out there that do just that, a variety of different products. We hold an event once a year and everyone comes out, and it's as pink as it can be, and people are with pink tutus. But at the society, we also let people know where their donations go. They can always get us checked out. And particularly at this time of year, there are some folks that are buying products that think that the money's coming to us, or think that it is going to a hospital. And so you really need to be very, very aware when you're making your purchase, and just really think about it. There's a lot of places that you can get this checked out, but it's a particularly hard time of year because we want to raise awareness and we want to bring in as many funds. It's fundraising is hard, and we're at a very grassroots level. But we're not selling our souls out there, and you really have to be very aware of your purchase power and really know where your money is going and what it's supporting. It's a hard time of year for someone, particularly with metastatic breast cancer.
Yeah.
We field a lot of phone calls from those folks when they see advertisements for Making Strides Against Boston event. It hurts them, but by the same token, I know that when I go to work every day and I'm raising funds, I'm not there because I'm making a large salary. We don't work for the society for that. We work to spread awareness and to bring in funds for the research. So we straddle. I don't know if there's a right or wrong answer. You just need to be very aware.
Right. So it sounds like, I mean, there's a kind of a double entendre with awareness here, or multiple layers. There's the awareness, of the breast, what we think of traditionally as breast cancer awareness, knowing what to look for, doing your self breast exams, being able to talk about it, knowing that it could happen to you. And there's that awareness, but then there's also this deeper level of being aware of the companies that you're purchasing from, or are they donating somewhere? Who are they donating to? Where's the money going? And if this is something that is important to you as a consumer or as a survivor and a consumer of these pink products, to find out these things and to be aware and to make the informed decision. If you're going to do it, at least do it knowingly. And that's a good point. It's a different dimension that I hadn't thought of as deeply until putting this panel together. Does anyone else have any thoughts on pinkwashing and awareness?
Yeah, I just want to echo, I think, what has been said, but I have been to many marches. I'm excited to wear pink and honor survivors and recognize those that didn't survive. And we all participate for a reason, and having something that connects us all, even as silly as a color, I think it makes a difference. It makes people get out there, and that's the most important point is that they're getting out there and they're doing something. And that's whether it's breast cancer or I do a lot of work with Light the Night for the Leukemia Lymphoma Society, and they do a walk every year. And a good friend of mine, when she was battling and in the hospital and not awake, like, it's one of the things that you feel like you could go, you're sitting there stewing, wanting to help people in a way, and going and participating, an amazing way to do that. But I also absolutely agree that there are a ton of information online, which means there's a ton of bad information as well. But with the right amount of due diligence, you can find the information on a nonprofit that says this amount of their money goes to research and this amount of their money goes back into the community to support these things that you intended this money to give, to do. So it's just about, going to the right sources for that information. I don't go to YouTube to learn about vaccines any more than I would go there to learn about which charity to give to. So I think it's that same level of research and diligence on where your money goes.
I think, I have some more questions, but I know we have a networking time too. I haven't seen any attendees post any questions, but I want to give people time to ask them. I have one final thought, I guess, one final question or food for thought, if you will. I guess it's a question because I do want to hear what some of you have to say. And this is for, specifically the doctors. And I'll start with Dr. Cassidy, since haven't heard from you in a little bit. We're in a period of time where society is polarized as to what they believe in about science. And, a lot of innovation is around science. And how do you, not only do people doubt it, but they defy it now. And, whether that's right or wrong, this is not a political question, but as an innovator in healthcare, how do you keep yourself and your team motivated and inspired to continue working in a system where a lot of the people don't believe in what you're doing? How do you keep going?
Yeah, I think that we're actually, where we are in Boston, we're pretty lucky because we're in a part of the country where a lot of the people are on science. But certainly, this is a really difficult thing to navigate, because I do see many patients who, because of their background or because of their faith, they do believe that things may get better on their own, that their cancer will disappear with a lot of prayer, and they delay their treatment significantly. And of course, biology, they all progress. So it is a really delicate balance of sort of respecting people and their beliefs and their values, but also trying to impart the knowledge that we have that is reliable and validated and scientific, and kind of balancing that can be really challenging. I don't think I have any answers into how to do that besides to sort of take the time with people and to kind of explore the belief system that they have that sort of underlies it. Because when you're rushed in clinic and patients are kind of refusing to accept your recommendations, it's easy to just document, okay, patient refused this and move on, than to really kind of spend the time that it takes to explore like what their fears are and why are they so afraid of a lumpectomy? Why are they so afraid of taking a medication? Like, what is it that's causing that? And I think if you can get to the bottom of that, sometimes you're able to make.
Good points. You know, it's interesting times, I guess I'll say, and leave it at that. And with that, I gave everybody a little bit of homework. If you saw, hopefully you read my long email, but I asked if each panelist would come up with a question to ask another panelist or to put to the panel. Has anyone come up with a question that they would like to ask another panelist that I haven't already touched on?
So I have a question, and this is, I think, what keeps me up sometimes at night. Well, a lot of things keep me up at night, but this one, I think, especially in this forum, it's really understanding how, from a medical device perspective, as we bring these solutions to market, again, with ports, it's such a specific case because there are so many touch points, but what do you think is really the best forum for us to encourage and facilitate that peer-to-peer discussion as, again, Dr. Ko, you're prescribing a port, and Dr. Cassidy or Dr. Karana, you might be placing the port and somebody else is accessing it. From our side, what can we do better, or what is I think the most effective channel for encouraging those peer-to-peer discussions, even on ports, which I feel like they kind of some of those devices get a backseat to the pharmaceutical drugs because there's just so much to keep track of. So I'd love to hear your thoughts on that.
Multidisciplinary conferences are pretty common in the academic setting, and those are, if not common, they're expected in the academic setting. And for all those who don't know what that is, it's where, once a week, a bunch of specialists who all in some way touch cancer meet and review a list of patients. It could be a complex case, it could be a simple case, but you're basically bringing to the table the latest guidelines, the latest techniques, the latest therapies. Now, if that's happening on a weekly basis in academic institutions, shouldn't that be happening in every hospital all over the United States? And anyone who's treating cancer? And the answer is yes, absolutely. So we have a cancer center in town here with 6 oncologists and 2 radiation oncologists. We have breast surgeons. We treat all types of cancer, but I show up there weekly, and whether it's me bringing the latest paper or the latest study to offer my techniques, what I'm trying to navigate in a community of private practice doctors is not always, well, what's the latest, greatest thing to do for the patient? But unfortunately, sometimes it is, how do I navigate the channels of referral patterns and I scratch my back, you scratch mine kind of situations, which still exist in medicine in our location. So I think my answer to your question, Lena, is, what's going to be best for the patient is to put aside all that and communicate, whether it be a weekly conference or, as we're moving into the virtual world, a weekly Zoom meeting is going to be so important as more clinicians are involved with the treatment of cancer of any sort. There's going to have to be a way to consolidate that information, because there's no way I can keep up with what Dr. Cohen and what Dr. Cassidy do unless they kind of condense it down into the nuggets that are going to be important for me to understand and present that to me. And I think as a physician, that's going to be due diligence. You know, we have to educate each other. We have to let our ego check them at the door. And, you know, I wanted to bring up, I just read an article about cryoablation of low-risk breast tumors less than 1.5 centimeter in women older than 60 that are, receptor positive and HER2 negative. Amazing. I can't wait to do it. I can't wait to get my hands on it. But imagine the, mountains I'm going to have to climb talking to a room of oncologists and surgeons, and they're going to look at me and say, who do you think you are? And luckily, I'm in a community where I've been accepted, I've been valued, but I know other folks in my profession and other physicians out there where they do have those challenges to, basically break the norm and be progressive and, be a disruptor, for lack of a better term. So being a disruptor in medicine is a really interesting kind of flag to carry. But I think the best way to kind of overcome those is going to be with open communication, checking the ego at the door, and putting the patient first.
I just want to say that I have obviously barriers to a medical profession because we're outside of the medical. Definitely much more into the for after active treatment and for the general of women who have had their treatment and sort of been signed off, essentially can go back to their primary physicians or their GPs here. And I think that for to open and to have forums like this, even of an innovation and a new approach for me to the doctors that we have in this panel, because the breast care nurses here in the UK will contact me and say, our patient brought this in and they brought it in and we've never seen anything like it, and we don't know, we don't know enough about you. Advocate it to our patients, but we don't know. And it's worked the other way around because we've focusing on the women that we've been working with and that it's been them that have gone back when the product's stage and brought that back into their care team. Care teams are coming back to us, but having that loop, and so it's not just dialogue between doctors that's important. There might be people who are out completely. I mean, I was working in a until 2 weeks ago. I to focus on Boost and working in a museum. So why would you say that you are apart from through doing by necessity because nobody else? I think it's really interesting. Everybody saying that we not just people who are communication and caregiving, but actually be open to those voices from people from a wider sphere of experience that might be a different angle.
I have a question from the audience that kind of fits in with what we're talking about. Carrie says, love the patient-centered panel. Where do you send your patients for emotional support that you feel is most effective for them?
I can answer that.
I actually do not have one personally. I actually have never even thought about that or haven't been presented with that. But in my field of what I do, I mean, I have had patients who have lost limbs from arterial disease, and basically we send them over to have a prosthetic made, and those folks do a good job of the whole emotional support during that journey. But in the cancer setting, I haven't really had to deal with that as much as probably some of the other healthcare providers here.
Dr. Coe?
I was going to say that there's not a one size fits all for emotional support. If you think about what people lean on for comfort, it can be and look so different. And so what I try to do is make a good connection with my patients, make them feel like they can be vulnerable and tell me, you know, what's going on in their minds. And then I always do ask, like, you know, them who their support system and network is, because everyone's is different. And then we do have some pretty good resources depending on a patient's comfort level. So it can look like anything from, we have a cancer support group here at Boston Medical. We can reach out to that if this feels like a person would benefit from that type of setting. And then sometimes I'll reach out to our social worker, who actually is like super lovely, and I think they might connect. And I sometimes will refer them to psychiatry if I feel like our psychiatrist, we actually have one that specializes in cancer patients. So I have that as a resource. ACS has loads of support. I mean, ACS is constantly, you know, providing lots of support. I would say not so much for non-English speakers that we see sometimes. It's harder for them to access some of that support, but there are, you know, lots of networks we have, especially at Boston Medical Center, because, you know, I think we see patients who come to our center and cancer is not their biggest problem. And that always really hits home for some people, and they're like, oh my God, cancer is definitely not their biggest problem. So we're working with a lot of other things as well. So.
And Julie, I was just going to say too that we, you know, throughout the year, we hold all different sorts of events and whatnot. And we often ask for folks who may want to address an audience, or it could be a survivor, you know, wants to share his or her experience. And I think that there's a lot of power in that too. It may, you know, maybe a couple of years through their journey, but when they're ready and they speak, that's a different type of healing as well that goes on. And, you know, both from the speaker's perspective and from folks listening to that, I think that there's really good synergy. So we've seen a lot of sort of informal connections made to support, you know, in a lot of different ways.
Yeah, and if I'm going to out Carrie, the attendee who asked the question. I actually know her, you know, and we've talked about this a lot, and, you know, how emotional support is so important. And if I can share a quick anecdote, when I was at the beginning of my journey, you know, I had resources at BMC, you know, social workers, and, you know, all I had to do was ask to be connected to somebody that had, you know, there's a program where they connect you to somebody that has a similar diagnosis, you know, both somebody that's come out on the other side. And when you're at the beginning, for me, I mean, you might not even know what to say. Like, you know, you need support, but you don't even know what kind of support. And it's a very I mean, aside from all the other challenges about being, you know, having a cancer diagnosis, you don't know what you want as far as help. And sometimes you don't want any help, and you don't want to talk about it, and you're not ready to hear from somebody that's on the other side or that can give you emotional support. And other times, you know, all you want is for people to ask if you're okay and to check in, but you don't really want to talk to them. So there's so many different layers of what is supportive, quote unquote, you know, what we need. And I was chatting with a friend yesterday, and I said, you know, people don't know what to say. You know, friends and family might not seem supportive, but really they don't always know what to say. And so they end up saying nothing because they're afraid of saying the wrong thing. And I think if you find yourself in a situation where you don't have, it doesn't feel like you have anyone to talk to, then it's, you know, especially important to seek out emotional support, maybe even professionally, because this is definitely not something that is, you can't do it alone. Awesome, guys. Oh, yes, go ahead.
Sorry, I was just, there's a lot of women in our community, some close Facebook groups that are specifically obviously about process and listening to women as we're making our products and doing what they need us to do. And that emotionally for women to feel like they're somebody who's making the products for them, but we're making it with them as well. That's been, people have commented, included and listened to because of the we've set up in our design methodology making. But also I think, being mentioned Julie earlier, I think it's really interesting that there's a lot of books and a lot of novels that have come out that are written by libraries, and I actually keep a little library of them here. Really interesting as a way for people and them from me to have a little read, and they just somebody's journey, but maybe in a way where you don't, if like talking with another person, but you can read through how somebody else has coped. A really viable way to support and understand a little bit more about the journey, necessarily getting bogged down or feeling that capacity to talk.
Yeah, definitely. All right, well, I think it's networking time. Thank you guys so